Thank you very much, Mark. Noisy. Really, I'm quite grateful to be here. It's such a pleasure to be among such a serious group of acupuncturists, and draw close, those of you who are here. I had a great conversation yesterday with Peter Deadman, and he was saying, well, you know, the problem is stroke isn't sexy. And it is true, stroke isn't sexy, but it is, of all the things that acupuncture is wonderful for, and we know it's wonderful for lots of things, it is the thing that it's used for the most in China. And so the hospital where I have been working since 2004 is pretty close to a Chinatown. So we have actually quite a lot of Chinese patients, and quite a lot of them have stroke, because there's a big relationship between diabetes and stroke, and also the vasculature in Asian patients is a little trickier, and so actually they're more prone to stroke. It's the number 1 killer of people in China, and only the number 3 or 4 here in Western countries. Over the years, whatever it is, 15 plus years there now, I have had 1 Chinese patient decline acupuncture treatment for stroke. They just really understand that it's what you do. And the reason they understand that is because it works so well. So for those of you who are here, I really want to give a thank you and an encouragement and a pep talk to find a way to make it work in your practices for chronic stroke. Unfortunately, statistically, the odds of one of us having a friend or a loved one with a stroke within the next year are pretty high. I don't want to make exact pronouncements, but just the number of people in the room we have, it's actually pretty unlikely that one of our lives won't be touched by stroke. And so what I'd like, the real emphasis of this talk is to connect the acupuncture you already know and practice, and I know there are lots of different styles, with treatment principles that people need during the various stages of their stroke recovery, and therefore empower you to do whatever you know how to do with whatever you have on hand, whether it's in your own office with your Japanese ion cords and all kinds of other things I don't know how to use very well, and direct moxa, which I can't do in the hospital, of course, and figure out how to do what you do to help people just using the treatment principles and the understanding of what's going on that we'll talk about. And then also there's so much you can do with acupressure and tuina and auricular acupressure beads, that if somebody you love, or even a beloved patient, were to be in the hospital, there's a lot of good you could do acutely while visiting them, and you should feel just fine about doing that. It's we're shy about using needles in the hospital where we're not entitled to, right? And that's appropriate. You wouldn't invite your friend the surgeon in to do a surgical procedure, But I've had a couple of questions about the barriers to working in a hospital. I'm happy to talk about that too if time allows. But I want to get onto stroke first. Just out of curiosity, I'm wondering who's here in the room. Can you raise your hand if you've ever had a stroke patient in your office and worked with them at all? Great, so more than half. And raise your hand if you are set up to be wanting to do that going forward. If you really feel as though you could, you'd like to, it's a real thing. Well, that's really exciting. There are so many stroke survivors, and at a huge range of capabilities, and there's so much that we can do for them. So I want to jump into all of that, but really welcome and thank you. So it's a lot to fit in. I often do roughly the same talk in a whole weekend. So we're doing selected highlights, and really, again, with the emphasis on treatment principles and connecting what you know. But I'll share a few of my favorite kind of toolbox tricks of the trade. So basically how we go about looking at a patient who has a stroke and figuring out what we can do to help, right? When I was getting ready to do my PhD, I knew I wanted to do it in stroke because it's such an important topic and because so much of what I'd been doing working in this acute rehabilitation center was stroke. More than half of our patients at that unit are stroke. I had quite an assembly of impressive, important international researchers telling me not to. No less than 3 continents worth of research has said that it's hard to get good results on stroke, and that's absolutely the case. And the reason why is this kind of statistical scattering you get, where if I've got osteoarthritis of the knee, you more or less know where the pain is within a 4-inch region. You more or less know there's a lot about someone who's got osteoarthritis of the knee, right? Once you look at, headache, I've either got way too much chi in my head or not enough, but it's a fairly well-defined set of problems to solve. With stroke, it could be anything. It's like saying got hit by a car, right? It doesn't say where the injury is in the brain. Depending on when it happened, where it is, and what region and how deep into that region the symptoms and prognosis can vary utterly. So for that reason, if you take a bunch of stroke survivors from a Western medicine perspective, they're already heterogeneous, and then you put on top of that the inevitable heterogeneity of some people are hot, some people are cold, some people are phlegmy, it's by that time you're doing so many different things, and we're coming out of a period where it was normal to do fixed research, fixed acupuncture point protocols for research, which, as you can imagine, for stroke, that's just garbage. The idea of doing the exact same points on 2 different stroke patients is, how wrong is it? Let me count the ways. It's completely the wrong project. So how to even, what are your coordinates in thinking about who a stroke patient is and how you might go about helping them? And the elements of that, so restoring cranial chi and blood flow, right? That's urgent right in the beginning, but it remains a priority throughout. And then the second big sort of chapter in looking at what's going on with the stroke patient is, has their chi machine recovered, right? The tree transformation system that takes in food and turns it into themselves, right? It's really common for stroke patients either to be terribly constipated, have urinary retention, or conversely to be incontinent. So if that's not working, there's a limit to anything else you can do, right? Doing normal channel chi acupuncture relies on the idea that your gyroscope is running properly. And if it isn't, you have to identify and treat that more or less first. And then it's time to do rehabilitation, right? So the first 2 items are sort of stroke recovery, and the third is rehabilitation, restoring function. And there's a little bit of a priority order to which deficits, right? It's much more devastating not to be able to speak than it is not to be able to use your right hand. It's not great to not be able to use your right hand, but if you had to choose, speaking, walking, swallowing, so how to stage through what to work on takes some finesse, and sometimes you jump stages because you might get a good result, and that would be encouraging, and then you could come back to it. So there's a fair amount of also just, I don't want to say jollying the person along, that sounds a little condescending, but keeping their spirits up. I mean, depression is so prevalent in stroke that there's actually not good consensus as to whether it's a comorbidity or just part of the problem, right? It's part of your brain has died. So there could be a justification for saying, well, of course you're depressed. You've got there's only 85% of you can show up for work today. Like, of course, there's less of you than there ought to be, and of course you're depressed. But then there's also, well, situationally, it's pretty depressing. So there's kind of keeping a sense of progress by shrewdly choosing things to work on that you know you can make a difference with. So that's our first section, is what we're sort of how to know what to work on. Then I'll talk a little bit about our sort of toolbox for working, and again, making sure that we have a decent repertoire of non-needling techniques, so that if it's a loved one we're working with, we can do that. And then I'll touch on some body and scalp acupuncture styles I use and resources for learning more. And in terms of resources for learning more, I should say that Angela and John Hicks have kindly agreed to host me next November. So if you are interested in taking the whole weekend, we will have it next November. And then before then, if people are treating stroke, I'd love to stay in touch. I think it would be a great thing to do to make a little Google group or something, and have a little, a forum between us. We could do webinars or something. I'm perfectly happy to just talk to people and support it, because I really think that it's a dimension of practice that we just could be doing much more of. Just like back pain and hip pain and sciatica. It ought to be a core service we offer. And it just needs a little thinking about. So then there's this manual. Raise your hand if you had a moment to pull it down online, or if you've seen it before. So it's freely available online. You can just Google. I've got a weird enough last name that you can just Google my last name, and there it is, Citkovitz stroke. And it's buried in my, extremely tedious 350-page PhD write-up, but it's this little 24-page stroke manual that's pretty tidy and easy to read. And again, you could just be handy to have it on your phone, just in case, someone you know and love is in the hospital. So planning for short and long-term care, and I will also talk about spasticity. I didn't put as many slides in about it as I'd like, but it's the sort of thing that starts happening after a month, and the muscles also get tight. So it's treated fairly similarly, because it's the same regions as moving the chi is moving the chi, whether the chi is slack or tight, right? We're still working with the same points. Any questions before we move on? No, great. Okay. So, as I said, there are three basic, does this work? Yeah. I can't point the laser at the screen. Maybe it's delicate. In regulating the cranial chi and blood flow, of course, we need to differentiate if it's a hemorrhagic or an ischemic stroke. I'll talk about what those are and how we treat them slightly differently. And then the function of the chi machine. First, we sort of clean up any of the wet spills that are still going on in the region. People often have aspiration pneumonia, or people will go a week after their stroke without evacuating their bowels if drastic action isn't taken. So we need to clean up mess, and then look at what's the underlying constitutional imbalances, right? Why they had their stroke in the first place, and what we can do to kind of rectify their current presentation. And then look at the deficits. And again, we like to say, first find the patient, right? If the patient's not in the room with you, that's your first order of business, is just to get them present and accounted for, And then speaking and swallowing are really key to them being present and being sustainable in their own lives. And then you work on, roughly speaking, proximal to distal motor function. First the trunk, then the proximal limbs and the distal limbs. So we'll go through each of those in a little bit of detail. Some general principles. Keep it simple. And I say this with all, empathy. My own tendency is to write elaborate little point protocols in my head that address every little thing, and oh, how clever, this point does two things at once, and then also it can. Over the years, I've learned that just as when you're speaking with somebody and it's not both of your first language, or if they've had cognitive impairment, you just need to speak slowly and with relatively short words and simple sentences. So for the acupuncture equivalent, what is that? That's basically our Madanyang star points, right? It's our big, strong points that move a lot of qi, our shu streams and our he xis. So there are absolutely reason to use particular points, and I'll talk about them. But by and large, either some kind of a very simple balanced treatment or a treatment that's off balance in a very meaningful way, which I'll talk about shortly. But really kind of short declarative sentences, keeping it simple for the body to understand. And then it's really fine to treat what you see. I think in our clinical practice with people who are sort of ambulatory, what is it called, the worried well, there's this idea that if we just catch at exactly the root of their puzzle, everything else will fall into place, and they'll pull themselves together. And that can be true when you've got a machine that's relatively well functioning, except for just this one thing. With stroke, it's actually a big fat mess, right? Like, it's the equivalent, we can say this quite literally right now, if a big storm blows through, there's just storm damage, and there's getting at the reason that the storm happened is somewhat incidental to cleaning up the flood and the mess of the dampness in all the houses after the flood, that there's just work to do and grab a mop. So I haven't seen it. Absolutely may be that there are, acupuncturists more brilliant than I who have magic points that they can needle and everything changes. But my day-to-day lived experience of working with stroke is of inch by inch, row by row, kind of regrowing a healthy chi machine and a healthy body. And that's what I feel capable of teaching you. So and the good news about that is that if you see spleen and stomach deficiency, you go right ahead and treat it, because it's there and treating it will help. If you see phlegm, you transform that phlegm, right? You treat what you see and you will be able to help. So don't ever be shy about not wanting to treat a stroke patient because you don't fully understand what's happening, right? It's also not like cancer where you don't fully understand what's happening and you don't want to get involved just in case you make it worse, right? With stroke, right now, it's as bad as it's going to get, and everything you do will be to help clean up. So yeah, our job is to clean up messes and help restore chi flow. So specifically, with ischemic stroke, so an ischemic stroke is where there's a clog in the pipe, right? There's a blood clot. It's interfered with the flow of blood in that in one of the vessels of your brain, and everything downstream. Everything immediately downstream from the stroke will die within 8 minutes, right? If tissue gets zero oxygen, it's gone. But the whole thing of everyone gets tissue plasminogen activator here, right? TPA. You raise your hand if you don't know what TPA is. Yeah, okay, so I'll talk about it. So it's a very potent anticoagulant that if you administer it within 3 hours of somebody having a stroke, then there's every possibility they'll return to something pretty close to their previous function. There are extraordinary videos of people quite out of it from a stroke, and literally the ambulance will radio ahead to the hospital and say, we've got a stroke patient, and the hospital will have sort of greased skids ready. The first thing they need to do is do a CAT scan to find out if there's a big spill of blood all over the place, in which case it's a hemorrhagic stroke, and you'd better not give anticoagulants, right? But if it's a clot, they give this powerful anticoagulant, and the clot dissolves itself, and flow is restored, and so all of the cells that were getting 75% of their blood flow, 50% of their blood flow, 25% of the blood flow downstream from the clot, they're there suffering, hanging on by a thread. They can breathe again. So that's great if you catch the person within 3 hours of their stroke. Unfortunately, that's not very common, right? Usually it takes quite a bit of time to get to the hospital. Pretty often people wake up having had the stroke. And then what is it, right? It's 8 hours since you went to sleep. Hopefully you got up to pee at 5 a.m. and your partner heard you, right? So in the States, they've extended the window to 6 hours. The thing is that there is a chance of bleeding out, right? If you get the super clot buster and it turns out that behind the clog a little bit of pressure built up and you have a tiny little leak, once you get that anticoagulant, oh my God, right? You're going to have a huge stroke, and in 6% of patients, a drastic hemorrhagic event happens. So that's no good. So you have to make sure to try to not give out the treatment to people who are not going to benefit from it that much. So over time, the benefit of the treatment gets less and less, right? Because all of those cells that are behind the clot, struggling for air, they just die. They die for 6 hours, and by 6 hours, you figure it's no longer worth giving that extreme clot busting drug. And then they actually continue to die for the next 7 to 10 days. So the stroke is still happening. So I've had a number of patients who felt terribly unwell, walked into the emergency room, and then will be wheeled out of the hospital because the stroke just got worse and worse over time. So it's not entirely uncommon for the person to actually have their function get worse, even though they're in their first few days of rehab, which, as you can imagine, is really disheartening. So, if you're an acupuncturist, what do you think you're doing in that time, right? You're raising clear chi as much as you can and descending turbid as much as you can. DO20 and Li4 obviously are key. Days 7 to 21, you still want to do a little bit of raising the clear and descending the turbid because there's still kind of swelling in the brain that will go down. And the faster you can clear that inflammation and edema from the brain, the healthier the patient will be the sooner. So points like stomach 36, Li 11 that are just independently from Western medicine shown to have strong anti-inflammatory effects. You could do acupressure on those. You could do needles on those if you had a moment to do a needle and had the opportunity. And then targeting blood flow to the lesion. So the Terry Olson, do you have that book over here, the Manual of Auriculotherapy? It's a terrific book. Anyway, he literally has a map, we'll see it later, of ear points, the brain mapped onto the ear. So you can, even if you're just with a loved one in the hospital, you can target blood flow to the lesion, even if you don't have your seeds on you. You can just pinch the area. Distal points, right? So the gallbladder channel, the other end of it for the head here. So that's an ischemic stroke. You're trying to clear out and it's a hunk of blood, right? It's a blood clot. There may also be phlegm involved. So you're trying to clear it out. With a hemorrhagic stroke, there's this logjam of intracranial pressure in their head, right? The lesion itself is creating pressure, right? There's this spreading blood. They've got the pipe hasn't just been clogged; it's burst. And so if someone ever complains of the worst headache of their lives, right, they have to go to the ER. We try and stabilize that intracranial pressure. So it's this, gently up and down. But in the case of hemorrhagic stroke, we want to be quite gentle with it. Once they're stabilized, then it's more or less the same principles. The farther along you go in your stroke recovery, the more similar your treatment principles for ischemic and hemorrhagic stroke are. So by the time it's 2 weeks, it almost doesn't matter, other than in evaluating your constitution to figure out what went wrong. Almost doesn't matter to the treatment. Your symptomatic treatment, your treatment of the sequelae is going to be pretty similar once you're out of that acute phase. I'll not talk as much about these because we're going to go through them in detail later, but acute messes can look like phlegm misting the orifices, right? They can be very out of it or very visibly phlegmy. Their lungs can be full of phlegm. Constipation, urinary retention, and incontinence. And then constitutional imbalances. Is there still wind is an important question, right? We talk about it as wind stroke, but again, I like the metaphor of a storm. Like, definitely we're treating a lot of wind damage, but do I see wind right now? Only sometimes. Historically, you can see why stroke got associated with wind, right? It comes on really suddenly, and there is a rare stroke presentation called hemibolismus, where the whole affected side keeps twitching. It's quite rare. I haven't actually seen it clinically. I've seen it on videos. Seizures. The brain extremely dislikes being touched by blood. There's an immediate seizure reaction, so a lot of hemorrhagic stroke patients have a seizure immediately on the stroke onset. And then we have what you call a focal seizure, where I'll be in the middle of talking and then I check out. And stroke patients tend to be prone to those, so that sudden onset, again, can be thought of as a wind symptom. And in fact, seizures are so common in hemorrhagic stroke that, at least on the rehab unit I work on, hemorrhagic stroke patients are prophylactically treated with anti-seizure meds. Is that, I know some of you have neurology experience, does that jibe with your experience as well? Or yeah, so anyway, on my unit, there's already seizure prophylaxis for hemorrhagic stroke patients. So therefore, we experientially hardly ever see much wind per se on the stroke unit. Acutely, then after the stroke, spasticity starts setting in, and that you can talk about as a kind of wind. How much blood stasis, how much phlegm? Basically, all strokes are kind of on a continuum from the one to the other. There are people who are, super heavy, and you feel as though the phlegm just kind of burbled up to their brain and caused the stroke. And there are others where, typically it's a smoker, where you just see all kinds of blood stasis signs, and there's not a lot of phlegm. And then underlying deficiency, right? A fair number of hemorrhagic strokes aren't your classic, what would you think a hemorrhagic stroke would be, right? You'd think it would be a livery person blowing a gasket. But a fair number of them actually have more of a spleen not managing the blood kind of a look to them, right? And you can see from the door which it is, because they're diametrically opposite presentations, right? Okay. And then the deficits, so critical functions first, right? The person's spirit, if they're not verbal, then you really can get a lot of information, even just can you connect with them in terms of your eyes meeting, right? Shen to shen. And it's very important, actually, to help them feel connected to and loved and understood with lots of eye contact if they're not verbal, right? Because just think how desperately isolating it is to have that. So to really just spend time sitting with them and doing stuff, iPads are actually really great for that. You can look through pictures, and it's rather hard to figure out how somebody's cognitive function is in there. If you ever look at your cat and think, what are you thinking? What is that little brain doing in there? It's just, again, not to trivialize in any way, but you really wonder how people are doing. And I'll go ahead and say, everybody wants to be healthy, everybody wants to be normal. So it often happens that if the stroke is on the left, the person's emotional apparatus is still in perfectly good working order. They can welcome you into the room and make you feel like they're fine. And if you ask them to draw a clock, there's a whole piece of it missing, right? That perceptually they're way off. And we had one patient, he was what's the head of a monastery? He wasn't a brother, he was the father, the spiritual head of the, anyway, the two nuns who I guess were charged with his care came in and started talking to me right away, and they said, oh, and by the way, can you do something about his drinking? So you knew how he'd gotten his stroke. As we talked with him, he actually, his cognitive impairment was quite bad, but he looked you right in the eye, and he said the wisest little nuggets of things, short sentences, but really right on it, and you just felt like you were completely in connection. Actually, his cognitive impairment was terrible. He just had a lot of practice interacting with people while not fully himself. He was just really good at it. So you did just have to watch out for how much cognitive impairment there really is, but it's really important to connect with people. And then for speech, so you want to, do they recognize their family members, right? And then if they recognize their family members, do they recognize you? That starts to give you a clue how together somebody is, even if they're not speaking. And then as soon as possible, you want to get to a reliable yes and no. Because somebody who has a reliable yes and no can participate in physical therapy. They can tell you if they're tired. They can tell you if they're wet. There's a lot of connection you can have if you can just get one of these, or even eye blinks with somebody who's got a brainstem stroke. If you can just, and that's communication, right? That's functional communication, and it's huge. So that's really the first place you want to get to. So just to jump ahead a little, we do 20 and 24 is just routine to get to that place of a reliable yes and no. For speech, they're closely linked together. Aphasia, which is my brain centers for receiving language, are having trouble, and dysarthria, which is I'm having trouble making the sounds of the speech. But clinically, more and more, I find that when I treat swallowing, which I do quite locally, right, with needles all around here, even the cognitive part, even the aphasia part gets better, not just the dysarthria. So really, more and more, think about, what are these points around here called? The window of the sky points? Yeah, I think about that a lot. So again, just knowing what those points are and having hands, you could be freeing up your loved one's window of the sky points just with your touch, and having, what they do, they connect the head and the rest of the person. So just having your fingers on them, one by one, and just really feeling for an open chi flow and trying to facilitate it, right? And gallbladder 20 and 21 are great for that. Do 16, so you can really just try and open up the whole, interface between the head, the outside world, and the person. Swallowing, freeing up these one of the sky points. And then there could be, I swear, there could be a whole profession that is acupuncture, speech and swallowing therapist, right? Speech and swallowing therapist is a whole job, or a speech language pathologist, they call it in the States. But there's so many different, right? Like, when is it the spleen channel? When is it the lung channel, right? Because what they're doing, swallowing is very complex. So in what they have to do, they have to get it in with their lips, which spleen and chong, right? Then their tongue, they chew, and then their tongue has to move it back. So heart, and then into the throat, where all of the throat muscles have to do this, ballet of closing properly in sequence, right? Because you get big trouble If they aren't properly in sequence, then the food kind of lurches back into the trachea, and then you have aspiration, and they can't eat or they'll get pneumonia. So to be able to, so then it's the lungs, so to choreograph all that, and I feel like I want to say, now go do, right? Because we have these tools. We know how to palpate channels. We know how to take pulses. We know how to free up channels. We know how to feel along the channel for what, so if I'm gummed up in here, then what lung point? Well, I don't know. Feel along the lung and see what's empty, see what's full. If they're in your office, put moxa on it. Don't wait for me to tell you magic techniques to do. You know what to do. Figure out what channels aren't firing and fire them. Akabane, who here does Japanese acupuncture or akabane? Any of you does 5-element use the akabane technique as well? Yeah, so think about, as you can imagine, especially, you have to be careful when people have, on the impaired limb, if there's sensory difficulty, but you can still moxa the jing wells or put the incense over it. And you can do the meridian balancing thing on their good hand to really get those channels back in shape. Okay. Yeah, I think that's, yep. Yeah, exactly. So it's all the brain, of course, and the question is it so remembering back to school, we have the leg and the arms and torso and then the head and face. So if there's a glob of phlegm or blood stasis around here, then my muscles aren't going to know what to do very well. But conversely, if my Broca's center or my Wernicke's center, my actual speech centers are affected on the left side, then I will have trouble creating output language or even understanding language. Mm-hmm. And so he looks, there's few enough of us, I think we have time to do this. Actually, no, let's hold it off for the speech section. So if they took off a piece of skull, then almost certainly it was a hemorrhagic stroke, right? They took it to relieve pressure. The language centers have been affected. Interestingly, in Chinese patients, language is less lateralized. Because why? Because their Chinese language is also art, and it's also got tones to it. It's got musical tones. So a big chunk of it lives on the right brain, and therefore there are Chinese left side stroke survivors who can speak perfectly well, even though if they were American, they'd be, they'd have aphasia. And then actually, I've seen 2 Chinese right side stroke patients who can't speak. But do you think that their speech comes back slower or faster? It comes back quite a bit faster because it's like a squirrel. They've got nuts stored in different places. The brain's like that. The more they learn about neuroplasticity, the more exciting it is. Because if you have even kind of 1 or 2 nuts stored somewhere other than the place that was razed to the ground by the stroke, then you probably can pick back up some function. So I feel like I'm on a little of a tangent, so let me get back on track, but we'll come back to that. The point that if there's any hardware left at all, if there are any neural connections, we can work with that. If it's nuked to the pavement, then it's a little harder. Okay, so for deficits, motor function from proximal to distal, and we start with balance and trunk stability. Because why? Because the only thing more dangerous and more difficult to work with than somebody who has bad trunk stability or bad balance is somebody who has bad balance and trunk stability, but their legs are really strong, right? You actually, there's, yeah, it was online. Sorry about that. I know there's a lot. I can, I figured they would copy them. I didn't think that it would. Sorry. I apologize. You can go get it online. There's a Dropbox link to this, so you could, even at the break, if you have a phone or something, you can pull it up. So don't worry, you have to write it all down, because you have it all, if that was the question. If somebody, often there's this boneless look of somebody who's had a stroke, and it's hard to help that person move around in bed. It's hard to help that person into a wheelchair, but it becomes even more difficult if they've got leg strength pushing themselves around, right? And in particular, it's quite common for patients to feel as though they're falling, and so they push out with their good leg onto their bad leg, which is exactly what you don't want them to do, right? It makes it really inconvenient. So you really try to do these big symmetrical treatments to just help them be steady first. And then if you had to choose between not being able to walk and not being able to use your arm, unfortunately you choose your arm, right? Walking is more important, it's more central to being independent, and it helps. Walking is incredibly restorative, right? Our chi machine runs itself by us walking, and so you really see a pickup in the pace of recovery once a stroke patient can walk. The glutes and hamstrings come back first, and then the quads, right? In general, extensors come back slower than flexors, right? The flexors are stronger. And then the vastus medialis in here is often the last to come, and you need it to stabilize. Dorsiflexion is often the last thing, and we'll talk, if we have time, about a little trick for that. I run e-stim with a couple of motor points and make the foot twitch, and I run an e-stim at the same time on their opposite leg points, so to remind the leg muscles and the brain area that they go together. Pretty often it pushes the person over the edge, and that's the difference between them needing a leg brace to hold their ankle up, otherwise they'll trip, right, and not needing one. That you can do that anytime. It doesn't have to be immediately after rehab. If people come to you with an ankle brace, try it on them, and I think you'll be pleasantly surprised how many of them actually get enough return that they don't need to wear it anymore. All right, and then upper extremity, middle cerebral stroke, the arm lags behind the leg and may not return at all. It often just doesn't come back. It's because the middle cerebral artery is quite large. It has a bunch of territory, and it has a bunch of little offshoots, and so it's very prone to getting strokes, especially in smokers. And it can just completely take out this whole arm area, and so they've got nothing. You can't restart the software because the hardware is gone. And so then you probably see people like this on the street. They've just got this arm that doesn't do anything for them. So the leg comes back sooner with most of those patients, and MCA stroke is half of strokes. And the return is often complicated by the fact that the rotator cuff, how does your shoulder stay in its socket? By the delicate balance of your 4 rotator cuff muscles. So if all of a sudden a couple of them aren't firing well at all, now the shoulder loses its stability, and you've got this painful shoulder subluxation. So we can help that a lot. What do you guys do for shoulder pain? I do opposite stomach 38, right? Then you mobilize the joint. Works beautifully. Like, do it right before therapy, and the therapist will be your best friend. Recovery generally goes proximal to distal, but every so often they can just twiddle their fingers a little. If they can, that's a terrific sign. It means there's a little something there. Otherwise, shoulder elevation is usually the first thing that comes back. So I always ask them, shrug your shoulders for me. Okay, now move them back and forth, right? You just start to sort out what they can do. And flexion comes back before extension. So the reason I did this little intro is I really wanted to say at this point, like if there were a fire drill and we had to evacuate the building, you would have the basics of what the treatment principles are, what you're trying to accomplish. Obviously, over 15 years, I've picked up a thing or two beyond that, and I'm happy to share it with you. But this is the overview, and I think it's a really important conceptual shift from this idea we probably all learned in school, right, 4, 11, and 15 to treat stroke. And actually, those are perfectly good points to treat an arm that isn't moving well. But as you can see, an arm that isn't moving well is like step 8, at the end of all these other things that you really want to pay attention to. And people will come to your office and say, my arm isn't moving well, can you help me? And you say, sure, but let's start with, I just want to get a sense of what else got hit in your body, what else is going on, because it's never just the one thing. And often people walk around with moderate depression and constipation for years, right? And it's just, they take lots of meds. And if we get their young being working again, they can be so much happier. I mean, it's as you can imagine, it's a huge quality of life issue. These sections to come will introduce the techniques and how we teach them, and there are 2 cheat sheets that are broken up onto the PowerPoints, and you can get the originals online. All right, any questions before we move on? Anything of a more general nature? No? Okay. All right, so acupuncture, right? Zong Fu and channel approaches. Well, organ problems, channel problems, and the constitution. The acupuncture we learned in school actually serves us quite well for identifying what's going on with the stroke patient. Then I think we mostly learned the scalp acupuncture map by Jiao Shunfai. It's the one that's in that blue textbook. I think it might be called Acupuncture, a Comprehensive Text. The one that's it's the little picture of the man. Did we all get that at some point? There's a little leg, and then there's the giant, he has giant hands and huge lips, the homunculus. So the leg is here, the upper extremity is here, right, the arm, and then mostly this third is the hand. And then the head and face, which again are giant in relation to the rest of the body. So that line, just raise your hand if you don't know about the basic motor line, right? Okay, so, okay. So that's, let's see, I think I have it right here. That's it. So it goes from Do 20 down to Taiyang. And there's the motor line runs right at Do 20, and then sensory is a little behind it. And again, it's divided into fifths, and the lower fifth is the leg, and then the middle 2 fifths are the upper extremity, and the lower 2 fifths are the head and face. So as you can see, I see, there it is, all right. So it's essentially, it's a TCM era invention, that motor line, and it's basically saying if we stimulate the scalp over this Western medicine brain structure, we can activate the Western medicine brain structure. There have been fantastic MRI studies of what acupuncture does in the brain, but they don't do them of scalp acupuncture because it's hard to put MRI, you can't get a good MRI of the brain when there are needles in the scalp. And so there's not absolute proof positive that needling over the brain in this way stimulates its function, but boy, do I feel as though I have a lot of anecdotal evidence after 15 years, right? It really does seem to work. So that's basically what we're doing, is we're stimulating the brain to rebuild pathways. So like that thing I was saying, I'll do it with the foot, where I stimulate the leg area and I make the foot twitch, or I'll do it with the hand and the arm. I'll make the wrist twitch, right? I'll just do Sanjiao 5 and then the Bashia points, and I'll run a current between them and make the wrist twitch. And then I'll have the same rhythm going on in the brain, and it just strengthens the pathway. It reminds, what they say, nerves that fire together wire together. So it just reminds the two they go together. And if there's any architecture left in there at all, it'll help to reinstate it. So the Jiao map also has these speech areas, right? Speech, this speech number 3 area is Broca's area, where you make speech for export. This speech number 2 area is Wernicke's area, where you understand incoming speech and kind of understand your own internal speech. So people who have a stroke here know what they want to say, and they struggle to form the words, and as they recover, they succeed more and more quickly. People who are injured in Wernicke's area may have kind of, they call it cocktail hour speech. They may have kind of a senseless babble, and it's not completely unrelated to what they're thinking about, but it's not really fully intelligible. It's kind of the stream of consciousness, non-grammatical patter, or you can get just repetition of one syllable. We had one fellow who would say pesh, 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 pesh. And so those speech areas I use all the time. They're also very helpful. So the politics around that, formation of traditional, what makes it into the big book of what's official TCM and what doesn't. So this Zhu Mingqing method also ran, right? He was the honorable mention runner-up. They were fighting for kind of primacy, and the Jiao Shenfa method won, and the Zhu Mingqing method lost. And the Zhu Mingqing method is more Chinese medicine-y. Anyone hear of that? Anyone heard of Dr. Zhu scalp acupuncture? Yeah, okay. So it's, I'm really fond of it. I actually use it all the time. I also do birth. So I use it all the time during birth, because if you put in scalp needles, they're quite stable, and they're, out of the way of everything. They won't get bumped or get in somebody's, and they're great for pain. So I really encourage you, even if you don't wind up treating stroke patients, do experiment with these Dr. Zhu points. They bring qi and awareness to the affected area. And I'll tell you how the map works, but basically it's ipsilateral, right? So because the motor and sensory fibers to the body cross, if I had a left side stroke, I will needle, we'll call it ipsilegionally, right, where the lesion is, or contralaterally to the deficit if I'm treating the brain. But if I'm using a Chinese medicine method to treat the qi, I will needle on the same side as the deficit. So if my right arm doesn't work, I'll needle the right side of the head. What's great about that is that if it's your family, or if you're in a hospital and you're treating every day, then you can alternate, and neither side gets too heavy, too tired, right, after too much needling, because scalp needling can hurt a little bit. Also, the Ju Ming Ching needle method is much friendlier. The traditional method with Dr. Zhao is to put in a thread, a 3-inch needle all the way down and rotate it at 120 times a minute and make a strong stimulation. I have a colleague who early in her career induced a seizure using that method. So working in the hospital and being relatively risk averse, I don't do that with the 3-inch needles. It's anyway with American patients. It's a stronger method that I want. So what Dr. Jewett does is thread these little. They're slightly longer than ear needles. They're 0.8, but you can perfectly well use an ear needle. Thread ear needles one after the other, so you're still following a line along the scalp, but you're doing it in a much friendlier way, and you can actually individually stimulate each of them, so it's more sort of chi friendly, right? You can also run an e-stim. You can just do a top one and a bottom one and run e-stim across the whole line, which you might want to do. Or you can also do so for pubic symphysis pain. I'll do just a little chicken foot of needles, right? Needle, needle, needle. So it's like a little arrow pointing at the painful place. And usually there's a horribly painful place right here. But you could do that. I'll show you in a sec. So this map of the spine I use all the time in my private practice. So do 20 maps to do 20, right? There's no do 20 is itself. Now reach up and feel your external occipital protuberance. Notice how it has a little ridge down it. So imagine that it's a tiny little sacrum, right? That you've got a wee baby sacrum right in your 216 there. Can you sort of see that? That's a little, okay, so then that's your sacrum. Do 20 is do 20. So now if you have any back pain at all, walk your fingers up, so you have two imaginary little bladder lines either side of your do line. So walk your fingers up and find your back pain. And I think chances are you'll have a nasty tender spot right where I've got one positive finding already. Anyone else got a back pain and also got a little tender spot right where their back pain should be? But you can actually feel above the sacrum you have a little indent, that's your lumbar spine, and then you have an out curve, that's your thoracic curve, and then for the parietal suture you have another little indent that's like your cervical curve again. And so I use these all the time, whatever body acupuncture treatment I'm doing. I'll also do the scalp treatment, and that just makes it stronger, kind of turns up the volume on the treatment and helps it last longer. The kind of balance method treatments, or the kind of treatments that Dr. Ziv is talking about, they're quite strong, right? You move a lot of chi right away, but they don't always last forever. So if you also do the scalp, the corresponding scalp needles, it kind of dials it in. So I can't recommend this strongly enough. For stuff like back pain, you just put in these needles. They have an immediate reduction in back pain, and then you have them move. So key to Dr. Ju's approach is the idea of breathing chi into the area. Put your hand on the painful area and say to the person, okay, as I stimulate this needle, I want you to feel like you're drawing good, clean air into this area, and then exhale strongly and send out all the bad chi, right? You really have a strong, what they call a Dao Yin, engaging the person's own healing mechanisms. So have them breathe for a good, 3 minutes into the place as you stimulate it, and they wind up feeling quite a warm, tingly sensation and the stimulation is just push, 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 kind of tiny little push, 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 or if it's really excess, you can sort of pull, 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 not like you're actually pulling the needle out, just like you're tugging it against the resistance of the scalp. Yeah, so try that just with whatever your needles you have on hand. It works beautifully. It is an Usher point system, so if somebody has horrible pain in their thorax, but they don't have a corresponding tender point on their Dr. Jew line, then this isn't the treatment. Like if there's no tenderness, then it's not going to work so well. But pretty often you'll find that there's the perfect corresponding tender point. Yep, question? So great question, when I do that, am I angling the needle down or up? So I go right along or parallel to the dew channel, going away from the top of the head. So it's always, scalp needling is always less painful going away from the top of the head. It just is. So it's very unusual that I do anything different myself. Okay, that's it. Great to alternate, so little pushes, disperse with little pulls. So the spine map for pain, right, is incredible. There's this in the front. So you see the head is at dew 24. Why does that make perfect sense? Because dew 24 is such a great shun point anyway, right? And also, I use it for sinus pain. Do you guys use it for? Yeah, it's like the root of the sinuses. So it makes perfect sense that that's where your head is. And then kind of the, crotch is up at dew 20. And sometimes, just for what it's worth, sometimes I'll find that the front map flips, and actually, like with pubic symphysis pain in pregnancy or postpartum, very often the atomically tender point is actually at dew 24. But you can do a kind of an upper, middle, lower jiao treatment here. I will admit I don't often, but if you have a patient who, so for example, if a patient isn't quite cognitively together, you might not want needles on their arms or legs where they could mess with them, but scalp needles are very easy to control. So if they have a tummy ache, you could needle that, right? Or if someone's got pneumonia, it's great while you're doing your other scalp needles, you can just pop in a couple for the chest. And then the other thing I want to point out about this system is that it has a really good area for the shoulder and also for the hip, for what it's worth. But remember I was saying shoulder pain comes up for stroke patients a lot. This shoulder area is enormous, right? It's a big, you get 3, you can get even 4 needles on that. Whereas the shoulder in this map, even if you're using the sensory line for their shoulder pain, the shoulder area is quite small. It's just right in there, and you could only get 1 little needle on it. So I really like the Dr. Jew for shoulder pain. And again, even if it's just a 50-year-old shoulder, right, regular old frozen shoulder, it's great. If the area is tender, then it's a phenomenal treatment to put a bunch of, maybe 3 needles in there at the tender points, and then stomach 38, and then mobilize the shoulder, right? It really helps it open up. Yep, question here. Sorry? I will use electroacupuncture. So do I use electroacupuncture? I use electroacupuncture more on the Dr. Jiao system, which is Western medicine oriented, than I do on the Jew system, which is Chinese medicine oriented. Dr. Jew, is not at all in favor of E-stem. Like, I would consider trying it on the shoulder area for the reason you're thinking of, because it would be so handy if it worked. But his stimulation, his dispersing stimulation on a really sore shoulder is worth a try first. Yeah, sure. Okay, any other questions about that? So do me a favor and just try it on somebody within the next week or two, because it's really, and also, we have a million things for sciatica, but I treat pregnant ladies in whom all of the things that I would want to do for sciatica strongly move the chi down here, which is not what I want to do if they're not week 37 yet, right? If someone comes in with horrible sciatica at week 32, the last thing I want to do is strongly disperse GB30. I know it's not on the list of official forbidden points, but I don't think it's a good idea to strongly disperse GB30 in a pregnant woman, right? I don't want to do that. So here's a way to treat the hip pain, but with points that are located up here, right? Which is exactly where you want to have needled if, God forbid, something bad happened, right? You'd say, oh no, I just put a few, you want to see how little the needles are? I just put them up here, right? And ear seeds. So with that and ear seeds, I find most musculoskeletal problems in pregnancy get resolved without having to do draining, needling. The last thing you want to do is take energy away from a pregnant woman, right? Even if the energy is stuck, you actually want to free up that energy so her body can reabsorb it, not disperse it and make it go away into the universe and not be holding her baby up or helping it to develop. Yeah? All right. So that's a couple of our main toolboxes. So that was scalp, right? The two different scalp systems. Now auricular. Auricular is a whole wide, wonderful world of its own. We're okay for time, right? It was 2:30 to 4? Yeah, okay, good. Do you guys know this book? Is this over here? Manual of Auriculotherapy. I think we're on to the third. Yeah, so I actually, is it the fourth edition that has, no, it's the third edition that has he changed the illustrations to be these fancy computer graphics, and I'm not sure if I like them better or not. Anyway, it's useful to have two different views because it's sometimes hard to see things in the ear. Auriculo, the program is really good too, but in this map, this book is really well researched, and it has this Chinese system of mapping brain structures onto the ear. And what's magical about that, it was probably, I want to say 2008 or 9 that I took his course, and it just blew my mind because what's the biggest problem with using scalp acupuncture to treat the brain is that the scalp only has one surface, right? And so, something just changed. So suppose that the problem is in the thalamus. The thalamus is this little walnut all the way inside the brain. You can't get there from here, right? So with the ear acupuncture, there is an inside. The ear has an outside and an inside. So you can treat the thalamus and the cerebellum and the basal ganglia, all this stuff that's deep inside the pons, the brainstem, that you wouldn't otherwise be able to treat. And you can just put seeds on it and stimulate them. So, I think even the most stricty pants hospital, if you say, oh no, these are just, they're part of my religion, right? What are they going to do? Forcibly hold the patient down and take them off, right? At a certain point, you're allowed to take care of your family, how you take care of your family. And I think we can slide ear seeds in, as long as, don't use the tacks, right? Because that's metal, and God forbid they need an MRI, and I lie awake at night with visions of, and I did, if someone is going to ask about magnets, feel free to use magnets if you use them in your practice, but do not leave them on. I had a colleague who put magnets on UB67 for a friend of hers, luckily not a paying patient, who was pregnant, and the woman wound up having to have a stat MRI because they were worried about, sometimes when you're pushing, you blow something in your brain. And the magnets melted in the MRI and gave her third-degree burns on her UB67s. So don't leave magnets in. I never leave any metal on stroke patients because you never know when they're going to need a hurry-up MRI. All right, so we'll see in a minute where they are. The third edition pictures are actually easier to read. And Olson says on the record, if you strongly stimulate ear seeds, which isn't always comfortable, but if you strongly stimulate them, they're not any weaker than needles, and you can leave them in, right? So it's a double plus. And then, of course, there are other more normal ear points that we know about: constipation, insomnia, depression, anxiety, shoulder pain, all super common in stress, so also very useful. But let's talk about these ear seeds. So here's the map, right? It's the brainstem coming down, and then the corpus callosum, which is that deep piece that connects your brain hemispheres, and then the occiput up here, and we all know this from occiput. Sorry about not having handouts. It didn't occur to me that it wouldn't happen. Has everyone got that one? Okay. So, and then this is the bottom half of that. So here is kind of the business end of where, can everyone see that? The little pointer? Not really. So the squares are where you're inside the ear, right? And the circles are where you're on the surface. And then these guys are zones. Now, unfortunately, although this diagram is nice and exact looking, with any ear treatment, it works best if you first do master points and then either palpate for tenderness, or even better, use an electric point finder to find exactly where the point is, right? And that has the advantage of, you can then give it a little stimulus with the point finder and then put in the seed, and then if you put it back in your purse, you know, nobody knows that it was there. All of these points in here, so I don't have time to go into it in detail. It's the kind of thing we do in a weekend, but like, so with that syndrome where they call it pusher syndrome, where you feel like you're falling and you push yourself onto your bad leg, the posterior hypothalamus point very often helps with that a lot. The thalamus, if you have a stroke in your thalamus, you know, it's a tiny structure very deep in, and so even a teeny little stroke can give you pervasive damage because everything goes through there. And also a thalamic stroke, sometimes because it carries all the pain signals, they can just all get switched to on, and you have just excruciating pain in your whole affected side. That's actually quite hard to treat. So again, that's where you really want to strongly treat the thalamus. Substantia nigra, great for Parkinson's patients, right? So there's a lot of stuff in here that, you know, it's extremely rewarding of study. And so along with the new employment category of speech therapist acupuncturist, there should also be like brain auriculotherapist. It's a whole world of study in itself. But again, I encourage you to think about it with whoever comes in your door. Substantia nigra, right? That's the part that's that, where's my pointer? 134E right here. That's the part that is getting eaten away. And you'd want to do that in the context of other constitutionally appropriate points, right? So for Parkinson's, it would likely be like sympathetic, Shenmen, liver, kidney, and substantia nigra, and master cerebral, right? So you would start with any of these points, you would start with master cerebral. Okay, but yeah, if you don't already have that book, I recommend it really highly. Any more questions on that before we go on? No, great. How are we doing for time? 10 more minutes. So Twaina, raise your hand if your school curriculum included, or if you got some Twaina. Okay, good. So most everybody. My sort of introduction to Chinese medicine before I even went to school was with a wonderful Twaina person, a martial arts and Twaina. I don't know why I'm hesitating for words. A guy called Tom Bizio, who, in addition to being a great acupuncturist, also is a Twaina expert. And I kind of worked in his clinic, and that was what helped me decide to go to acupuncture school. So I sort of come from a perspective of you want to feel as though you're moving qi with your hands, right? You'd start with the idea of moving qi with your hands, and then acupuncture needles are like little, long, highly effective fingers. But that if you have this idea of what you want to do already in your body, it really helps the treatment work well. And it's very nourishing, right? Like if you think about like what's the nature of a needle? A needle is sharp and cold and made of metal, and it pokes in. So without any intention, if you just let it do its thing, is it going to supplement or disperse, right? It moves qi. Its nature is to move qi. Its nature is not to nourish qi. So of course, what we cultivate is our ability to, put it in just the right place and to nourish the qi with our hands. But that's not the way the needle's own constitution is setting itself up to roll, right? Versus Twaina, which is people touching people, right? Like that's inherently nourishing. And again, especially with a stroke patient who's frightened and traumatized and depressed and wondering if they'll ever get back to their life again, and who if you want to hang out with your grandma, but conversation is not that easy, it's a wonderful way to spend time with them where they're not called upon to have a conversation, right? Like acting normal can be very tiring for people. And so to be able to say, no, Ma, it's okay, you just lie back. I'm going to rub your shoulders for a while. But you just go to sleep. I'm just going to rub you, right? Just to have a thing that you're doing together is really lovely. So there are lots of reasons why the Chinese patients in our units tend to recover more quickly than the Western patients. The physical therapists all think it's because the Chinese patients work harder. And, I won't dispute that assertion. I'll just say that the fact that their sisters and wives and husbands are all in there 24/7 doing Twaina on them, I think it also helps. So you physically supplement, and then it's not like you're not moving, right? If you do Twaina on a limb, you're moving the qi nicely, but you're moving it in such a nourishing way, right? It's a yang within yin kind of a thing. It's movement within nourishing. So it really helps rebuild the affected limb in a way that just needling alone or even e-stim is a different tool for a different job. So more and more, we've got this exciting fascia thing, right? Oh my God, the sanjiao might be the fascia, right? That the qi might be this little electrical current traveling along the fascia. So that's in there, that there's this sense of tensegrity, that the fascia maintain themselves at approximately an even tension. They're not too tight, they're not too slack, they're about ready to respond to any bad thing that happens. And when half of the body, the tensegrity, is all of a sudden shot and the limb is flaccid, I use a lot of like the shaking and the bouncing and rocking, and I'll swing the leg, just a little bouncy, fun movements. There's this cautious, rigid feeling to post-stroke, or also, again, Parkinson's. Twaina, I think, is indispensable for quality of life for Parkinson's patients. It can soften their rigidity so much. And there's a lot of kind of emerging evidence that our nervous systems learn from each other, right? Entrainment, that a healthy nervous system can teach balance and health to an impaired nervous system. So really think about that. Think about, first calming and grounding yourself, and then coming with a therapeutic touch and just playing. Like, do whatever you do. It doesn't even have to be formal Twaina, but just finding a pleasant rhythm. And again, like it's like holding hands or something. It's just a way to visit with the person's body to make it a pleasant place for their spirit to root in again. So there's shaking, rocking techniques, Traeger method, if you want to Google that. You can, as an acupuncturist, I think it'll be pretty easy to just visually get a bead on what they're doing. It's this body work method where they use a lot of shaking and kind of freeing up. And Traeger in particular is good for Parkinson's. Use it on affected limbs, not like you can't use it on the unaffected limbs, but it's great on the affected limbs. And then on shoe points to nourish, I also, pick up your foot if you have time, and kind of chafe in here. It's your whole. If you can reach your bare foot without too much trouble, it's even nicer. But your hand kind of goes all the way down to kidney 1, and then all the way up to kidney 7 and 8. So that's like almost a third of the kidney channel that you're warming and activating. You can either for yang deficiency do it like a Boy Scout starting a fire, and for yin deficiency do it slowly and gently. And it feels wonderful. Like it's a great way to start the day. I don't know how I'd treat plantar fasciitis without it, right? Nourish the kidney, warm the foot. So I'll do that for almost any stroke patient as a way, if I could give them herbs, I would, but I can't, so I do this chafing instead. And then one last thing I'll leave you with is abdominal round rubbing for constipation. So say you have an affected limb that's not good for anything, and that in theory sensory stimulation would be good for it, but how are you going to get sensory stimulation if you can't do anything? Well, take your good arm, pick up your affected limb, press on your ring 4, and then make circles, right? Ascending colon, transverse colon, descending colon, right? With a fair amount of pressure so that you're actually sort of physically pushing the digestate along. It's, even if you don't have an impaired limb, it's a fantastic treatment for constipation for anybody. But it's particularly nice either to do to somebody as a way of caring for them, and then as they get well, as a way of helping them. I mean, think about what a physical therapy this is. They're having all this sensory stimulation on the affected hand, and they have a sense of doing something bilaterally. They're doing a task for themselves to help themselves. So it's actually, self-efficacy is a big deal in illness. So that's a really important treatment principle as well. So we have our break now, and I think that's it for the toolbox. Yeah. So we'll get back. We're right on schedule. We'll talk about putting it all together.